Good afternoon, everyone, and thank you very much for being here, and thank you for your patience. This meeting, as you know, through public notice, was delayed by 1 week, so we could get the report on 5B. And I appreciate everybody's patience, and we'll get started. So, Dora, can call roll, please.
Okay, Janine Miller. Here. Jan McGordy. This is Carmel Angelo. Here. Ace Barish. Here. Ross Liberty.
Here.
Lloyd Weir is absent by prearrangement. Mark Myrtle. Here. Ted Diamond.
Here.
Shannon Riley. Here. Thomas Allman.
Here.
Donna Muschetti.
Yes.
Perfect, okay. Thank you very much for being here. Has everybody had a chance to look at the minutes? If so, is there anybody who would like to make a motion to either correct or approve the minutes? Donna Muschetti,
Yes, sir.
would you like to make a motion?
564, should be 564
Wait, where are we?
on the second to last page,
Okay.
page 6. The nominee office is at 564.
Okay,
And for continuity, on page 5, it should be member Angelo instead of member Carmel.
Yeah.
Thank you.
we know you read them, very good. So is that a motion to approve as corrected?
Approve as corrected.
Okay, is there a second or another motion?
I second.
There's Member Diamond second. Any public discussion? Has anybody had a chance? None? Any questions? All in favor say aye. Any opposed? Hearing none, so carried. Thank you very much for your thoroughness of that. Moving on to communication. Confirming since the minutes have, or the agendas have come out, we've had no communication. Okay, very good. Public expression, we certainly welcome non-agendized items to be discussed at this time, up to 3 minutes at the podium. And if there's anybody who'd like to address the commission at this time, the floor is yours. Please state your name and you'll have 3 minutes. Okay, we'll move on. Discussion and possible action item. The Stepping Up initiative is by me, and I want to read my notes. So, in a coup from the police department, the sheriff's office hired retired Chief Chris Dewey to work in our training division. And Chris is doing an excellent job, and he's working very hard on the Stepping Up initiative, working with mental health on this. And my push to have this in September is not going to work, not because of our attempts of having it done, but because of the difficulties in getting the correct instructors to come to the training. And so it is not going to be a 16-hour course, it's going to be a 24-hour course. Some Stepping Up classes that we're taking, 24-hour course, going to be February, March, and April, one in each class, one each month. It'll be for first responders, mental health providers, and mental health concerned citizen members, parents, teachers, nurses, whoever. The good news on the instructor part, and the instructors, just to give you an idea of the cost, for each 3-day class, if you look at the instructors and the cost of the instructors and travel and transportation, it's kind of expensive. It's $15,000 per month. However, the post, the Peace Officer Standard Training, and the STC, which is the correctional equal to law enforcement training, these are reimbursable. A portion of them is reimbursable, and they're certified. So the law enforcement officers and correctional deputies who will go through this will actually be certified through the state of crisis intervention experts. So I don't know about experts, but crisis intervention employees. So we appreciate the work that Chris Dewey has been working with mental health on this, and we're looking forward to giving, probably in December, giving this board a full synopsis of what's going to be covered in those 24 hours, and the details of where the class is, and this class is not going to be closed. It's going to be open to anybody who would like to go through the 24-hour course of the crisis intervention. All right, any questions on that? Janine?
So I just wanted to add really quick, we did look at, just to talk about the cost, because we are, when you hear 15,000, it's a lot, but when we look at the capacity of the room and then the number of people, if we are able to fill it to capacity, we're looking at less than $200 a person to get this training. So I think it's important to also look at it as how many people we're able to train, and that if you look at it per person cost, we're really looking at about $200 a person to get this training.
That's a good way to look at it, thank you very much, and it is a top-notch class, you know, once it's become certified by the state, they only certify them after they've looked at the synopsis and see who the instructors are, so thank you. Jan?
Yes, regarding stepping up, as it has been stated before, that the most important thing about stepping up is getting a collaboration of all the agencies in the county, and I'm wondering the status of that. Has there been a meeting with law enforcement, the court system, behavioral health that can help the purpose of stepping up go forward?
There haven't been any meetings that I know of. However, in reading the Board of Supervisors resolution from 2015, the purpose of stepping up was to divert or get out people who are incarcerated who are mentally ill from the criminal justice system. And so maybe it's a little different the way you understand it, but I'm leaning towards what the Board of Supervisors resolution was.
Well, that was the purpose of the initiative completely. But if you look deeper into the stepping up, it depends upon making it work, depends upon a coalition among county agencies.
Right, I agree.
And that was very
And so
clear.
while their meeting hasn't happened yet, I certainly believe the meetings will happen. But Chris Dewey's in charge of this, and Carmel. Well, hey, is there anything
I'm
more?
not in charge.
Okay, Carmel.
No, I'm not in charge on stepping up. I think that what I don't recall, and Sheriff, maybe you do, but I think the issue that I see with stepping up is that we need to have a lead with stepping up. And I'm not sure if that's the mental health department, if that's the sheriff's office. You know, I agree that the point of stepping up is around mental health clients in the jail, but I think that the activities that you're speaking of and that were in the resolution, you know, really need a lead to do this. So it's either going to be mental health, the sheriff's office, or whatever. And honestly, I don't remember if the board appointed a lead on this.
They didn't, but I think that through working
Is
with
it
mental
mental
health,
health?
yeah,
If it's mental health, then maybe we can, well then if it's health and human services, then maybe we can get a report at some point as to what's happening.
And so we have had a couple meetings, Jan has, we've attended them, and we have, yes, and we haven't got the turnout we had hoped for, but with some outreach and with Chris working with mental health, we are planning to try to get a meeting scheduled in September. We have more parties who are agreeing to participate. The court has stepped up. Probation has assigned a lead for probation, and so we are looking to have another meeting in September, and hopefully we'll have more participants going forward.
so not a planning meeting for the February, March, April, but a
Correct.
meeting toward what Jan is talking about.
Correct.
Okay, got it. Any more discussion, questions, comments on Measure 5A? Okay, moving on to the meat of the matter. 5B, the Kemper Needs Assessment Report Presentation and Rollout Timeline. And with discussion possible action, Jed has been our liaison, but if you don't mind, Jed, I'd like to start with a presentation of 5B Kemper on the report. Is that okay? Sure. All right. Mr. Kemper.
Good afternoon, Mr. Chair, and members, Lee Kemper with Kemper Consulting Group. What I'd like to do is a brief overview for you in about 10 minutes, kind of hit the high points on the study that we completed for the county, and sort of summarize our recommendations to then kind of move to a question and answer perspective. As you know, we were hired to do a gap analysis looking at programs and services in the county and identifying areas of need, and then in that context make recommendations regarding the use of the Measure B revenues. So in summary, what we found is the two continuums of care for mental health and for substance use disorder treatment are incomplete. With regard to substance use disorders, It's a very small set of services, and it's not really a continuum. It is a small set of services. A more comprehensive continuum would be equivalent with the organized delivery system that Medi-Cal is seeking to implement in counties. We have recommendations about how we suggest you proceed in that context. With regard to the mental health continuum, we also see that it's incomplete because it's missing some key ingredients for the residents in your county needing care. Specifically, the lack of a crisis residential treatment facility, the lack of day kind of programs or partial hospital programs, and in particular, a more robust set of wellness and support services that reach into the various communities across the county. In the context of need, much of your current service delivery system for adults is focused on placing people in inpatient settings out of county. So we also identify the lack of an in-county treatment facility as a key missing element. The data that's included in this report came from a variety of sources, but the utilization data about mental health came from Redwood Quality Management Company. And it came from the dashboard reports that they publish regularly. So the 2016-17 and 17-18 data is all from reports that they put out on a quarterly basis. What we've done is just arrayed the data in a somewhat different fashion to try and show it year to year and show some distinctions of treatment overall. What we see is that there is a growing level of crisis mental health assessments, and that this is placing increasing burdens on the local delivery systems that are providing this service. Notably, the hospital locations where this occurs, as well as the crisis access locations that RQMC operates. But the real impact that we're talking about here is on the hospital. So we see this as an area of concern. Then finally, in the context of utilization, it's important to note the level of increasing placements that is occurring in inpatient settings out of county. And we point to an increase in the average number of people who are in care in 16-17 from 11.7 people to 15.1 people. This is a substantial jump in 1 year, and it's roughly a 29% increase. So within that context, then, we offer recommendations about how to utilize the Measure B revenues. In particular, we believe that the revenues need to be dedicated across a spectrum of services to build out a more comprehensive continuum of mental health care in the county. And we believe that a goal needs to focus on reducing the need for and the utilization of inpatient psychiatric care, whether that's delivered in county or out of county. At the same time, we need to simultaneously have that kind of capacity in the county. And taking that statistics that I gave you earlier of an increase to 15.1 persons per day, we're encouraging a 5-year goal of reducing that by roughly 50% in 5 years. So that instead that number is 7.6. With regard to the substance use disorder treatment service area, we're recommending that 10% of the Measure B funds be allocated to expand the access to substance use disorder services in the county. And we do this contextually to whatever the decision might be by the county regarding the organized delivery system, with the understanding that there are so many steps to be taken there. And we think work needs to get going right away on substance use disorder expansion, and believe this is an appropriate use of the funds. We think those could be incorporated into a larger ODS expansion if the county ends up going down that path, or alternatively, we'll make an important investment nonetheless. What I'd like to do is turn your attention to some of the key data that we identified. The first is on table 3, which is on page 16. Page 16. It's the overall mental health utilization. And it's table 3. And again, these data were from our QMC. And I'd like to actually publicly express my appreciation to Camille and Tim Schrader and their team at our QMC for the assistance they gave in the report. in providing the data, and the timeliness of that was very helpful to our efforts. What you see here is a chart that shows the unique persons served. So those are the unduplicated, unique individuals served. The full service partnership participation, so there's the number of partnerships going on. The level of crisis assessments, the number of inpatient psychiatric hospitalizations in the crisis line content. What you see here are substantial increases year over year in each one of these areas. And I think as a comment, just to sort of ground this is a substantial change from where your county was 2 years ago with the prior contractor. So one of the reasons that you're seeing these kinds of numbers is because of the responsiveness of your current contractor to intervene in these circumstances. That's an important thing, and I don't want that to go unmissed. At the same time, the numbers are going up very fast. And this should create some concern for you about the balance in the system and the strategies that can be undertaken to solve for that. I could go into more detail there, but I'm going to basically stop on the data there. What I'd like to do is basically take you to the end of the document where we present our recommendations. The first thing I'd like to say is I think it is highly unusual that the voters of a county would pass a half-cent sales tax and dedicate all of the revenues to behavioral health. So I think the residents and voters of this county should be applauded for that effort. And by taking that action, by creating a new opportunity to improve, strengthen, and make more complete the system of behavioral health in this county, whether it's for mental health or for substance use disorder services. We offer you a guiding principle about how to think about these revenues then in that context, and that is on page 43. We basically recommend that the guiding principle should be the development of a comprehensive mental health services, continuum mental health in Mendocino County that provides a broad range of services, supports that remediate mental health conditions at the earliest possible time and reduce the need for inpatient psychiatric use. At the same time, we believe that you need to have that kind of inpatient psychiatric capacity to meet that level of need. So we walk through and we give you a set of policies that we recommend that be adopted by the county. These are basically good government kind of concepts, if you will. The first is these are new resources, so they should supplement the resources that are in the system, not supplant them. Sometimes there are some clever maneuvers that can occur. So as new dollars, let's keep them in the system as new dollars. We recommend a biannual review process on the use of the revenues and their expenditures and how they're improving the continuums of care. We recommend a prudent reserve, which we've identified in the subsequent pages, so that you can carry over some of the resources in the first 5 years to covering costs in the next 5 years when the amount of collections will be less. We make a recommendation regarding the way to account for the money and the way to report on it, so that these funds are given a separate identity and that the taxpayers understand where the resources have gone and how they fit into the system. We recommend a 10-year strategic financing plan, which we've proposed in these documents. And finally, we recommend that the data be provided to you in a more discrete way regarding utilization by individuals across the county, so that we have a better sense of how people are being served in various parts of the county. If you turn to page 45, there's a spending plan there. Whenever you put a budget together, you always have to kind of pick sort of ballpark numbers. So we know that there'll be roughly $38 million that comes in over the first 5 years. We've picked $37.5 million because it's about the same number and it's easier to do the math. And then we've allocated out the dollar amounts that we think should be dedicated to these different activities. You'll see the crisis residential treatment. We have $4.75 million here. The hard number estimate on that is $4.66. The psychiatric health facility, our estimate is 7.5 million. Let's say for the sake of argument, that number is set is $10 million. Okay, that number would be 10 million and other numbers would have to be modified in a proportional way to account for that. The crisis stabilization unit number is really an annualized figure for allocating funds to the unit to support its activities. These would be dollars in addition to reimbursements that would support the unit. The support services expansion is essentially a way to make the current sort of array of wellness and support services more robust and to expand them more aggressively across the county, including things like mobile outreach, more hands-on kinds of services to individual people and their families where they live. There's a thing that happens in our service delivery systems, and we expect people to come to the location. And this can be a real challenge for people when they're suffering certain kinds of mental health or substance use or health conditions. It's tough to get there. So being able to reach out and touch people where they are is an important component of the way we do our supportive services, and that's kind of our concept for reaching people. The FSP expansion is for those folks at the highest level of need. These are the anything it takes population. We think that there is a real opportunity to expand on that, particularly for your multiple system users and, importantly, your multiple users of inpatient psychiatric care to the extent that they're not being met. Then we have the substance use disorder component. That's roughly 10% to be allocated according to a plan that we recommend that the PHRS director and stakeholders prepare. And then also supportive housing pool. And this is a dollar amount tagged to addressing the needs of conservatees and homeless mentally ill as a way to invest resources in local service delivery, not things that are out of county. There are a lot of things to talk about in this report because we've provided you a variety of data, but the reason that we did this is to essentially help provide you with a baseline against which your efforts can be compared, and you can look back at the data that are provided here as a base for your comparison. So that's why we told you about the EQRO reports and the level of quality that's occurring. I know the county just went through another EQRO study within the last month or so. That's why we gave you the context for what inpatient psychiatric hospitalization looks like across the Northern California region. Because these are all things that are contextual to today and what your thinking is going forward. I'd like to say that this was a really interesting assignment because we had the opportunity to look across the system but also into various facets of it. And I think one of the things that was most compelling to me was talking to families and consumers about their needs and bringing that home, that they can feel so isolated and left alone in their illness. And so the service system needs to be able to reach the population, the clients and the families in a way that we're not currently doing. Exactly. And there's an incredible amount of opportunity here with these resources. And I hope that this report that we've prepared gives you a foundation for discussing those ideas and coming up with what you believe is the best plan. So I'd like to take any questions that you have.
Well, actually, thank you. I'm going to ask Jed to do a presentation, or to do it, and if he wants to go to questions, and that's
Perfect.
thanks.
My presentation will be relatively short. I was appointed by this body to be a liaison with the Kemper Group to just have information back to us as this report was being developed. So I wanted to say a couple of things. One is I've been working in the mental health field for more than 40 years, and so I've worked at various parts of mental health system, and I just want to acknowledge Lee and the Kemper Group for, I believe, it's a very comprehensive report. I believe it took into account many of the questions that we as a committee had put out that we were interested in getting answers to, as well as hearing from the larger community. I'm also aware that I've been reading this for the last week since I got it, and I've taken 15 pages of notes, and I have numerous questions, and I don't feel I've really been able to digest the report fully. So I think what I want to just acknowledge, and the fact that there's so many people here in the audience, I think both speaks to the interest that came for passing this measure that allowed these issues to be discussed, and also the interest and the concern that many people have as we get down from the idea of it to the practicality of it to what are we actually going to do in our county with the funds. So I would like to have as many questions as we can today from the group here, the committee, to try to clarify things that we want to know, and I would hope and I suspect there's questions that the people here in the audience have that they would like to have addressed, and hopefully we can stay here as long as at least we can, given the limitations of time that we have, to get as many of these questions answered, because I think there's both a desire to move ahead as quickly as we can, but also a desire to move ahead with the real solid knowledge that we know where we're going, and we feel hopefully some confidence that we can do this relatively together, because nothing will happen well unless there's a general consensus from our community about what we want to be doing. So with that, I'd like to suggest we open it to questions.
The Commission will open up for questions or comments, and then we'll go to public comment, and then we'll get Mr. Kemper back up. So who's on the Commission, who would like to start? Janine?
Yeah, so first, I just wanted to say a quick thing. I wanted to thank Kemper Consulting for doing such a comprehensive report. I think the report provides a nice outline of the needs and challenges of our system. And I think it provides a nice framework for expanding services in our community. And I personally look forward to working on the next steps and the recommendations. And as a behavioral health director and a family member, I second your opinion that it's amazing for us to have this sales tax and to be able to provide services. My question is, as we look at this and we're developing sort of this strategic plan, one of the challenges I find is parity across the insurance companies. And while Measure B will remove parity in the sense of the Measure B funds, do you have suggestions on how we work with the insurance companies, the mild to moderate for Medicare, to advance services within our community across the insurance companies as we kind of look at Measure B and look at services across our community?
Well, I'm going to ask a question back first.
Yeah.
What interaction have you had with different health plans in the county, the private sector health plans, not necessarily partnership, as well as some of the third-party payers that might pay into the system?
So we've worked a little bit with Beacon and obviously Partnership Health Plan, and I've worked with the clinics to talk about so the clinics and us have come together to talk about our concerns. And so one of the next steps that we're at with the clinics and behavioral health is coming out as a group and talking about our concerns and where we see parity not meeting as a next step to talk to private insurance and partnerships.
Okay, well, I guess I would suggest maybe a two-track process, okay? I think that's an important track that you're on because you're going to have the experience from the public system side. And I'm thinking of the community health centers as being a part of the public system more because dominantly it's a Medi-Cal and Medicare-driven population. So I think that's important. But I think it's also really important, really as a part of planning out the wellness and prevention components. And probably the SUDT piece as well is to be able to reach out to the private health plans and say, so we have this unique opportunity to expand our system to provide this array of services. We want to talk with you about how we can partner to make these services that we're delivering complementary to things that you are already doing and to make services that you are undertaking complementary to what we will be developing. and looking for a way to partner with them around as sort of the first experience of developing a relationship. Because I think if you can start to build some things around this developing system, you can also put on the table, we have some concerns about the way people within the sort of third-party insured world operate and how they interact with our system because services aren't available there. So there's a hard conversation, right? And there's an easier conversation. So I would like to see you sort of undertake both sort of strands at the same time. Figuring out what the conversation is with the public sector side that puts the hard things on the table, while you're concurrently saying, we have an opportunity, how can we work with you? Because I think building trust together is an important ingredient. And you do want to be able to weave these. One of the funny things about parity is not funny, and that is that parity only means whatever somebody decides it means in the moment. And that somebody could be an insurance company, right, about whether or not they do provide that type of service, or it could be a governmental agency, but there's no uniform standard that everybody is applying equally. And so it ends up being contextual, where your context has changed. Your context is measure B, and you're trying to build on a system. So that'd be my suggestion.
Thank you.
All right, thank you. Any other comments from the commission? Questions, comments? Sure.
So, Lee, first of all, I want to say that I thought this was an excellent report. I have 2 copies that I've marked up. I think it's so good. A couple questions that I do have, though. When you go to the almost last page on 46, and you talk about program development action steps, and you speak to the CEO doing an RFP process to solicit proposals for a psychiatric facility, and then number 4, which is an RFP process to solicit proposals from local hospitals. Could you speak a little bit about this? Was it your intention that we would go ahead and solicit proposals for both, either a model where a hospital had 4 beds and compare that with a standalone? Was that the intention here?
That was the intention. What we've included from a money point of view in terms of the budget on the strategic financing piece is our estimate of what the POF would cost based upon our discussions with leaders of a couple of leading kind of private sector psychiatric health facilities in California. So that's sort of the number that we've been operating at. But we also recognize that there are 2 ways that you can expand inpatient psychiatry here in the county. Either with a psychiatric health facility, which would be a freestanding 16-bed facility to qualify for Medicare, or by having a wing or a set of beds in a general acute care facility. And in these instances, it's a little different in terms of structure, because with the hospital would be the owner and the provider of such services. And with the psychiatric health facility, as we outlined, there are different ways for that to be owned and operated. But what's the same is that they expand capacity for inpatient psychiatry. So, in our conversations with representatives of Howard Memorial Hospital and Ukiah Valley Medical, there was clearly interest in the concept of an expansion for inpatient psychiatric, whether it was specific psych beds or a psych gero wing. The numbers were sort of open to discussion, but there was interest. And I think my response to that as a consultant is to say, okay, then show me. And the only way for you to be shown is to actually go through a formal process that requests it. So I think that it would be fair for the county to consider doing 2 RFPs at the same time. We're going to do inpatient psychiatric, or one RFP that says, these are all of the vendors that are eligible to bid. Come in with your best proposal and tell us what you would do. Now, there are decisions that policymakers need to make before they take those steps. It would be good to know where. the building is going to go, or at least a couple of options. And it would be good to know whether they were going to be retrofitting something, or they were going to be basically tearing something down and starting from scratch, or the land is vacant. So those are all important ingredients in that equation. But ultimately, there are two avenues, and the revenue for the federal share of the funds comes down through separate mechanisms at the state level, but the non-federal share of the Medi-Cal match always comes from the county, and it's always from the realignment money, either off the top or from the county money that the county gets itself and then pays.
On page 25, when you talk about crisis stabilization units, you talk about Nevada County and Napa County, and both of them operate in the red. I'm wondering, is that common with the crisis stabilization unit? I mean, is it possible, I don't know if you can answer this, but is it possible to run a crisis stabilization unit not in the red? I mean, without putting general fund or Measure B dollars in there?
Well, I think in all instances that counties that run various components of their delivery system, they patch together a set of revenues to fund them. And what has occurred in these two relatively new CSUs is that package of revenues hasn't been enough to meet all of it. So whatever amount of realignment money the county got, and whatever the reimbursements were from Medi-Cal, and if they were able to pull down a little MHSA money or what have you, that in total hasn't been enough for those two particular counties. And we call attention to that because, you know, these are relatively new. They're in counties that are more comparable in size to Mendocino than the others in the example. And it's our belief that this service, the CSU, would be of sufficient value that an investment of Measure B funds to kind of cover that gap makes sense. And that's a good utilization of these resources because it creates a change in the dynamic of care that benefits many parties. Your administrator benefits because it centralizes activities and it hooks it up with a crisis residential treatment, makes it a ready access into that venue for care. For law enforcement, it means it's one place to go for the most part, and you can hand off to a secure setting, and so you save on the time. Obviously, with on the coast, that's going to have to be developed in a complementary way. And then for the hospitals, it means that people are not coming in and utilizing bed space on ED beds that could otherwise be utilized. So we think it's a good investment, but as you'll see in the recommendations that we have about that, we do believe that your contractor should put together cost estimates. So what's the volume? What's the patient mix? What do the revenues look like? You know, how is it that we put the final numbers together so you can determine, is it 500? Is it 350? You know, we've tried to put essentially what we think is a reasonable number in there to give you a basis for taking that next step.
I have one final question. So in reading this a few times, there's one thought that I have, and I just want to be certain that I'm my perspective is what you have put on paper, which is that for the county to develop a 24-hour psychiatric facility, that this is absolutely doable and certainly a necessary part of our continuum of care. But to do that without shoring up the whole system of care possibly could lead to failure. So the way that a 24-hour psychiatric facility would work, or basically a continuum of care and mental health that would actually work and be successful, would be to shore up the whole system. And when that's what I'm thinking that will come out of this, along with the fact that our services are somewhat Ukiah-centric. So services are necessary in the outlying areas. We don't have enough services. And you talked about isolation, and I've heard you talk about isolation more than once. And so in what you're proposing, is my perspective accurate in what you're proposing? And do you see a way to actually deal with the clients and the families that would somehow break this sense of isolation if we were actually, and is there enough money actually in Measure B to do everything that's in this report.
Okay, so I'll go off my memory, what you said, and try to answer the questions.
And that's all, I won't say another word.
That's
I'm just gonna
okay,
have a
that's
question.
okay. I'll say at the outset that if you take our numbers of, say, 5 million and 7.5 million for the crisis residential and the psychiatric health facility, and let's say you take another $2 million for the CSU. Okay, so now you're at roughly $14 million. That's $14 million out of $37 million. I think that what you're hearing from me is we think that's a really powerful and important investment, but you're seeing that the recommendation is that more of the money is going into the other things that build out the continuum. Because a service system that only can respond to crises will only respond to crises. And I think if you look at the ordering that we have on how to spend the money, year 1, 2, 3, and what have you, the first priority we put in there is building out the crisis residential treatment and CSU facility. And then also the supportive services expansion, the FSP, the supportive housing pool, and the SUDT. So those are all on the services side. Then the second and third year investments flip from crisis residential over to the psychiatric health facility, because you're going to need time to do an RFP, so we're assuming you're not going to need all the money until really the end of year 3, is when final sort of construction costs and things like that are going to come together. So then we've distributed the resources throughout the other components of the system. Now it's very important that we haven't told you what we think those specific services are in wellness and prevention or supportive services or substance use disorder, because we think more work needs to be done there to address the very things that you just described. How do we reach these communities? I think the mobile outreach teams are really important and powerful, but contextually, they're tiny. You need to grow the footprint of that kind of intervention that reaches out to people one-on-one. One of the things that was so powerful to me is a couple of the people I talked to in the family and consumer group said, if I had somebody to talk to, if I could get coaching on how I could kind of put these things together and plan for my recovery, that's a much more personalized kind of system than a system where you have to go someplace. And you have an opportunity to take what I think is a very good framework that you have today, certainly powerfully different than 2 years ago, on the adult side specifically, and build upon that now to that next level.
Thank you.
You're welcome. All right. Come down the row here, Dr. Barish.
So one of the issues we have is that lifting the load from the sheriff's department and the hospitals, you know, there's been a lot of emphasis up to date about psychiatric health facility. I like what you say about the #1 priority being crisis residential treatment and crisis stabilization, and supported by the fact that, as luck would have it, I know that Redwood Quality Management had the plan of doing this even before the Measure B committee existed, but the funding didn't come through as hoped for. And but because of the fact they were involved early, now we have a shovel-ready project that we can get started on immediately. And my impression, at least, is that this would actually, in the end, do more to relieve the burden on the emergency departments and the sheriff's department than, as you say, I think that the locked facility is certainly important. And but as has also been said before, the extent to which we have to use that facility is the extent to which we've already failed. And it would be nice, and we're already somewhat downstream when we get to crisis stabilization, crisis residential treatment, again, as you say. But nevertheless, as far as a priority project now, I wonder, it seems to me that it would be also the fact that it's ready and it's quickest and it's probably cheapest, the staffing is less, that it'd make a lot of sense to me to start with that project.
Well, I'll simply validate that. We think that's the first thing to do in terms of your facility construction, and that's why it's in the first year expenditure. And also because you've already been raising revenue through much of 2018, those dollars are pretty much available when you need them. But I think we agree that the most immediate impact on the need for inpatient psychiatric would be to have the crisis residential piece. The CSU is a way more to organize and centralize that assessment process and to relieve some of the other parts of the system that are burdened by the high level of assessments.
Okay, Ross.
So I worked, try as I might, I wasn't able to get through the entire report. It took me half the day just to write up an acronym list on the front. I should have actually had Carmel as a study partner, given that she read hers 3 times. So anyways, and I remain confused. Looking through the on page 45, which I hadn't gotten to until you just brought it up. It seems like the odds on favorite, the most support that any single facility had was the old Howard Hospital, and the budget came in at, I'm sorry, was it 16 million or something with that, assuming
14 million.
14 million? Is that assuming prevailing wage?
It's 12.1 to 4.7, I think.
Okay. So and I don't. It seems like we're that this budget recommends pursuing a continuum of care, but yet I don't see that there's any one budget line item here that would cover that expected cost. So maybe I missed it a little bit, my hearing.
When you said that expected cost?
So that if we wanted to do a single facility for $14 million, and I don't see it, and maybe 2 or 3 of these add up to that, but I'm not quite getting it.
We didn't pivot off of that estimate from the old Howard Hospital. The estimate that we provided was based upon our discussions with leadership of 2 of the California delivering psychiatric health facilities, Telecare and Heritage Oaks. And their estimate to us of building a new facility based upon the most current facilities that they've been working on was between $5 and $6 million. So our estimate took that high end of the $6 million range and increased it by 25% as a contingency, and that's how we got to $7.5 million. The number that came for the Howard Hospital renovation is from a separate contractor.
Of course. No,
Right. And so in essence, that kind of gives you a sense of range. I don't know, for example, what it would cost if it were not a renovation project at the Howard Hospital site. It could be substantially less than the estimate there if you were simply to raise the building and use the ground as opposed to try to retrofit the building. We haven't tried to independently investigate or verify the estimates that were given to us by the PUF developer contractors. We took them at their word based upon talking to high-level officials with those companies.
And I can check with Carmel on this, but she having read it 3 times, but I don't know if the supporting document, I'm just teasing. So I don't know if the supporting documentation is inside this report, or is it available that supports that number?
Well, it was through verbal interviews with these individuals.
Okay.
And so it was the totality of the cost, and there is a site reference on this. But I think the point that you're making is you're not seeing where that money is. And what I'm saying actually is that money is showing up in the line item that says psychiatric health facility, and right now the number is 7.5 million. So if you increase that number, then you would need to make a pro rata distribution of a reduction in your allocation to other things.
So I thought what we got was an estimate of $30 million to build a 16-bed unit. I'm not a contractor, so I don't know.
That was a number that I heard stated by someone. when we came here in April.
Not buying into that. Okay.
Because I know that one of the facilities that's just being built in Sacramento by one of these particular contractors is coming in right around $6 million. So I think what it comes down to is, what does it cost to build a facility that serves this singular purpose? I think it's actually a comparable cost with the crisis residential treatment facility coming in at $4.66 million. That's a new build on vacant land.
How many bed was that facility?
Is that 11?
So it's a combined, it's a co-located
Right.
crisis
CSU?
access CSU for 4 and 10 bed
Right. So 4 plus
crisis
10.
res.
So I actually think if you're talking, ground is vacant,
Yeah, Greenfield site.
then we're talking something in that $7.5 million range. If you're talking about retrofit, what we were told in talking with another of the developers, Respet, I believe it is, to estimate something in the range of $300 per square foot. However, we know that that estimate is subject to volatility because so much of that is driven by what is the site that you're renovating? What are the sorts of mitigations that you need to address in that? So I think an RFP process is a way to test the market on that in terms of both the willingness of somebody to come in and build it, as well as what it's going to cost to do it one of a couple different ways.
I appreciate it, thank you.
The old Howard Hospital site was also much bigger than the pub. There was room for a lot of other services in that building, so it's kind of hard to directly compare.
So I think that's an important point because one of the things that may be a distinction here is the set of assumptions that went into building out that building as opposed to the set of assumptions that go into building out a 16-bed psychiatric health facility. If there's substantially more capacity for other things, then it's not really an apples and apples comparison. It's really two different things. And so I think as a part of your deliberative process, it would be helpful to know, so what is involved in this particular bid? Where would the psychiatric health facility aspect of this be? What are the add-on costs associated with something else? Are those an essential component of this? I mean, there are a variety of different questions that could be sorted through to get to good answers.
Okay, Ross, any more?
No, that was very enlightening, thank you.
Mark, you're up.
Yep. So if you had to prioritize based on money, and we had to make a choice between a crisis stabilization unit, crisis residential treatment, or psychiatric health facility, you know, with all of your inspection and interviews and everything that you've done through this process, what choice would you make?
Even if it was a zero-sum game?
Exactly.
I'd start
Because I
with-
think that's way what we might be dealing with.
Well, I'm going to disagree with you in the sense that you have a revenue source that's coming in for 5 years. And you'll already, by the end of this year, have booked something in the range of $7.5 million. That being said, we've told you, by the way we've arrayed the dollars in that chart, that we think your first priority should be on the crisis residential treatment facility with the CSU adjunct. We think those are the most powerful and impactful thing in this system right now. The psychiatric health facility, we think, is a really important ingredient because you're still going to be placing people in inpatient psychiatric care, and it is better to have a facility in your county that you can get access to easily because you have more control of it, either through contract or ownership or what have you. And also it makes it easier for people to transport and keeps all of your services in the community. So that's why we kind of put those two pieces together in a year 1 and then really a year 2 to 3. In terms of the shoring up part of it though, as we've said, I think in the report in a number of different ways, if you only do crisis, you're only going to do crisis. So you have to build out those front-end components, and that's why we recommend dedicating those other resources the way that we do. We think there's a lot of work to be done on what those services should be, and we didn't try to get prescriptive about that, other than to say we need to reach people where they are.
Yes.
The cost to operate a PUF unit were between $3 and $4 million.
Right.
So we don't have the money to operate one of these facilities. So from what I'm getting from you is maybe we could build a facility, but we'd have to have a contractor run it.
Well, remember, the way that you fund an operating facility is the same way that you're funding out of county inpatient psychiatric placement right now. So those dollars that are being spent at hospitals in Napa or Vallejo or Sonoma, those dollars instead would be held here and would be allocated to that psychiatric health facility. I'm not saying that's the only facility that would ever be used by RQMC, because for the client's needs, that might not be the exact appropriate place. They might need to go out of county. But for the most part, that would be the main sort of location for that. And those resources that come from realignment or general fund or MHSA with federal match, those are the same resources that they would use to fund that activity. Similarly, on the crisis residential piece of it, they're going to be using those same kinds of dollars, pulling down federal Medi-Cal match to run the crisis residential treatment program. And I know that the RQMC folks have a whole sort of budget for what it'll take to run that facility and what their revenue sources are, what the federal match will be, et cetera. The dollars that they're using there are dollars that they might otherwise be using to send people to inpatient psychiatric. But what's happening is they're coming in at roughly half the cost to run a crisis residential program than what they would be at in an inpatient psychiatric setting. So they're making savings on those dollars that then allow them to essentially reinvest or sort of shore up other aspects of the system.
Okay. I'm a contractor. I'm a public works contractor. You referenced getting information from the directors of, it was Heritage Hospital and ResPAC. Were those estimates based on private companies building those businesses or public entities?
They were private companies building them. I do not know the answer on whether or not they were doing them under a formal contract with the county. They end up serving the county back, but I don't know the answer. So I'm going to have to follow up and get an answer on that question for you.
Based on the numbers that you presented, I believe that they would have to be privately funded. Working in the government sector, there's rules with prevailing wages and mandated wages for certain counties, and they increase the cost, double to sometimes 2.5 times of what private entities would be. And if we were to make a capital investment in Measure B funds, we'd be paying those wages. So when we look at the distribution of funds based on the numbers that are presented here, they're skewed, because they're going to be a lot more than $7.5 million to build a facility. So getting back to Helmer & Sons, they are a public works contractor. They just completed a hospital that wasn't publicly funded, and they have a good handle on what the cost of building is. So if we were going to take their numbers of remodeling the old Willits Hospital and put that into a square foot number and apply it to the square footage we'd need for a PUF unit, that would be a closer representation of what we need, but it'd still be undervalued, because I don't know how big that hospital is, but it's a lot bigger than what we'd be building. So that's my question about making choices between one and the other.
Well, so let me come back to the priority study. If you start with the crisis residential and the CSU, then what you have to figure out, if you say, for example, it's not 7.5 million, it's 12 million. Let's just say that. Okay. So that means that out of those next 2 years, you have to come up with 6 million each year. So year 2 and year 3, it means you need to prorate the dollar distribution in those years differently. It doesn't mean that you can't do all of those things. It just means that you need to prorate those other investments in a different way. I think from our point of view, those are still your top priorities. Crisis residential and CSU, followed by the psychiatric health facility, with a concurrent investment in those other areas. You know, the year 1 dollar amounts here are going to be collected by the end of this year. From a budgeting point of view, they're not going to be budgeted for expenditure into some new expanded effort until July 1 of 2019. So you have an extra 6 months of revenue growth in there that then becomes a part of your sort of, it makes the money a bit more maneuverable on how you can move it from one year to another and how you can make the investments that you want to. The other piece is, these are dollar amounts in total and also allocations by year as a way to help you kind of think about what kind of investment you would want to make. But it's not uncommon, particularly in the first year of a program, for you to have to ramp up to that level of expenditure, so that you might say, our annualized number that we want to hit is $1 million, but in year 1 we got there halfway. In year 2 we got there 3/4 of the way, and in year 3 we finally hit $1 million. Okay, well, you've just saved your revenues in the first 2 years that you can move forward into a subsequent year, or that you can dedicate back to something else. So I think there are lots of ways to work with those numbers, and I wouldn't personally be daunted by the numbers being higher than the estimate that we've given you, because you have running room within the revenue collection.
So if we were to staff a PUF unit, what proportion of funds would you say would be held locally versus brought in to our services? Do you know that answer?
When you say, how would it be financed? How would the operation of it be financed?
How much money we'll be bringing in that we're not paying? Because
Well,
the way that I see it is there's $3 million going out. You're saying there isn't $3 million going out because we will be able to supplement those services by not paying to send people out. Correct?
yes.
Okay.
So
What
you're,
proportion is that of
well,
the budget?
we have to actually, I don't know that I'm in a position to give you a hard estimate, but of that,
Percentage-wise.
well, if you look at the budget that we have, this is on page 49. And you can see in the PUF hospital, all the dollar amounts that are listed there. This is on page 49. This would be under the RQMC table on their budget. So this shows you dollar amounts that are allocated for, in essence, inpatient psychiatric care.
So 1.4 million,
It's,
about.
What's your total coming
it's,
in?
well, that's just for the PUF, so if you,
Right.
the hospital case is probably double that.
Yeah. So when you add the hospital piece of it, there's additional amount on top of that. So what ends up happening is half of this revenue is from the county, and the other half, for the most part, is federal Medi-Cal match. So if I'm going to place someone in St. Helena Hospital, I'm going to send my 50 cents to St. Helena Hospital, and the federal match is going to come down and pay St. Helena Hospital. But if that same patient can go to the PUF here in Mendocino County, I'm going to send my 50 cents to that PUF, and then the federal match is going to come to that PUF. So it's really a question of where, you want to make the allocation.
So looking at that, we're gonna have $2 million coming in when it turns to an 8-cent sales tax. And with this, we're gonna be the puff unit will take $2 million.
But remember, these monies that are the Measure B monies are on top of the existing mental health system. So by changing the service delivery framework here with your Measure B money, you're changing the utilization of money in the base dollars, those existing resources, so that those dollars get spent differently. You're not creating a new obligation to yourself out of Measure B money that you can't fund 6 years from now. You're repurposing the way you use the existing resources and moving them into things that are something other than inpatient psychiatric.
Okay, well, I'm not seeing that, and that's where the problem is. But what I don't want is to strap the county with a deficit, which you've seen in your report that has happened with 2 other facilities that aren't puff units. Right?
Well, that was a shortfall on that CSU.
Right. Oh, it's a CSU,
That's a
sorry.
CSU.
Yeah, okay.
Right, which we try to account for by proposing that you fund that. I think your concern is exactly right on, because you want to make sure that your system is sustainable. Let me go back to a key principle that we offer you at the beginning. These resources in Measure B should be to supplement, not supplant, the dollars that are already going to the system. So that means they are additive to. They can change the way these dollars go. The goal is to get more out of these dollars while you use these dollars in a strategic way.
That's it for me.
Thank you.
Jen?
Yes, I'll try to be brief because I know there's a lot of people here who also have questions from the audience. So if we start with, I think, at least from your report, the importance of the crisis residential program, which is at a particular place, it's already geared towards 631 South Orchard in Ukiah. And I'm thinking now, and part of my questions have to do with the whatever residential facility we're going to add on to that, where that might be. So first question is there a value for having a puff unit close to the proposed CSU unit? Does that need to be close by, or should it be anywhere in the county and still work well from your perspective?
Well, what does close mean?
Well,
Mendocino County, yeah.
other than Ukiah, one of the questions obviously is, would we use the old Howard Hospital? That would be in Willits.
Right, so that's how far up the road? 20 minutes? 20 minutes.
Yeah.
Right. So I think everybody sort of views time and distance in different ways. I remember when I first moved to Los Angeles as a kid, and people would say, how far is it? And they'd say 30 minutes. Like, yeah, but I don't know what that means.
3 miles.
So it's one of those things where it's contextual to what works for your system and what people accommodate on a regular basis. An hour is probably hard. An hour when you have inclement weather and it makes it 2 or 3 hours is even harder. But 20 minutes or 30 minutes, I think these all become viable, particularly if you have a location like a CSU with a crisis res where you have a location to stabilize, because then what you're doing is you're stabilizing and transferring. You're not trying to shove them into something as fast as possible, and you're not with the same kind of urgency and burdens that you might have in a hospital ED setting.
Okay. And my second last question is, it sounds like for a residential psychiatric, the options that you suggested were, one, adding beds to an existing hospital, which you suggested could either be Ukiah or Willits.
Right.
second suggestion, possibility, you talked about Howard Hospital, Old House as a particular place. Were there any other, obviously you could build if you had a land wherever. Were there any other physical facilities that you came across that were possibly other than the Old Howard Hospital as potential sites?
Well, let me just say for the record, we haven't vetted any site or really looked at any of them with any scrutiny. So I'm not really in a position to tell this body what we would recommend about a location. I have heard some alternative county properties suggested that might be alternative to the Old Howard Hospital or something else. But those are things people say in passing.
Right.
So I would have to defer back to this committee and to the discussions about that.
Okay. So that's part of the reason, if I understand right, you would talk about putting out an RSP that would
Right.
actually find out who would want to do something where.
Well, I think a key thing is you have to figure out the where is your location before you ask somebody to give you a bid on what it would cost you.
Got it. So the where has to come first.
Yeah, you have to
Okay,
figure out the
thank you.
where part. And I think there's a deliberative process to do that.
Okay. That's all I have.
Anna, you're up.
Thank you very much for your report. This was a lot to digest, and I was laughing because like Ross, I had to make a glossary of acronyms. It was fun, I learned a lot. And the advantage of sitting here today is that a lot of my initial questions have kind of been answered already. I do have a couple of questions. On page 5, there's a reference to, kind of in the middle of the page, it says, finally, we recommend Measure B funds be allocated to a supportive housing pool. And maybe I've missed something, but I don't see much other description of that in the report. Could you describe for us what that means?
Well, you're right. It was touched on, and then it was deferred basically back to BHRS with your housing authority sort of recommendations. In section if you go to the section pertaining to LPS conservatorships, starts on page 21. These are individuals who are unable to care for themselves, and government steps in and provides care and support for them because they're unable to care for themselves and they don't have someone else to care for them. And as this section describes, there are, relatively speaking, a small number of people who are conserved each year, something in the range of 60 to 70
In our county.
in your county. But the cost of those people is running at roughly $2.5 million. And on the adult side of the equation, and most of these people are adults, those costs are in addition to all of the other costs that you're already seeing in the mental health system. So that, say, $2.5 million is a number that is a continuing number for these types of individuals. Now, they don't all stay for a whole year. Some return home, some expire, but you then have new people that come in behind them. So that this is a recurring number of roughly 60 people. And as is pointed out in this section, roughly 2/3 of those people are out of county. Out of county. Placed in inpatient settings, and the care is being provided to them because the county, doesn't have resources like that in the county. So our expectation was that some of these resources could be used for a supportive housing pool to address the needs of this type of population, the conservatees. And I think, BHRS and the public guardian and stakeholders would need to sort through what would be the best approaches for this, but develop some of the service delivery capacity that doesn't currently exist so that those individuals could remain in the community. Then additionally, there are various kinds of supportive housing programs that you have in the county. I think you're implementing an expansion of one in particular. But there is a growing need around homeless mentally ill for some type of short-term location of service and residential care, or some type of sort of sheltered housing or what have you. So some of those resources could also be dedicated to that. Again, it would need to be sorted out through more a deliberative process by your DHRS director, public guardian, and housing authority, and what have you. Yeah.
DHRS, I don't know. They go to my list here.
BHRS, your behavioral health and rehabilitative services. So that would be the county. Why didn't you just say that?
We're civilians here, right?
I know.
This isn't our day job.
Thank you.
You're welcome.
And then one additional question that I think is probably beyond the scope of this report, but I'm, I guess, calling upon your expertise in the interviews that you did, and that's kind of an analysis of the staffing. And do you have any sense of whether staffing the recommendations that are put forth in this report, is that feasible, sustainable, realistic for our county? I think our existing medical facilities have been pretty open and public about the difficulties that they've had recruiting and retaining qualified staff. And so I guess I don't know if I'm asking for a comparison to the stability and the staffing at comparable locations, or whether you have any insight about our existing job market pool.
Well, let me
candidate
clarify
pool?
your question, if I may, because
Sure.
are you asking me about staffing as it is currently constructed with county government? Are you talking about staffing within, say, the hospital systems? What is the sort of venue that you're focused on?
We're talking about the addition of new services, the PUP unit, for example, which, since we're shipping so many people out of the county already, I assume that's the creation of new jobs within our county. So I'm asking about our ability to recruit and retain those types of jobs here in Mendocino County.
Well, I think that you raise an important point. And let me turn you to page 36. Because we've tried to outline for you considerations that are common to each psychiatric health facility option, and then sort of unique considerations for each one.
Yeah.
There are two really important elements of sort of the framework of a psychiatric health facility. The first part of it is you have to build it. So you need a qualified contractor, and you have to have good qualified expertise to oversee it and manage it, make sure it comes in on budget, on time, all of those things. That's a suite of skills that the county will need. If you are going to run the psychiatric health facility, then you need to staff it in the way it's listed here on page 36. You need a clinical director, an on-call psychiatrist, 17 staff over a 24-hour period, etc., an LCSW. That's where it is. Because now, as the employer, it is your obligation to make that happen. That's different than you've hired a contractor, and that contractor has the responsibility to make that happen. So I think that becomes a part of your equation in thinking about the, do we own and operate? Do we own and contract out? Do we contract out the whole thing? Those are important ingredients in the conversation, because it's one thing to be an operator of these programs and have experience doing this over some period of time and know what it takes in these kind of jurisdictions to get the talent that you need, and to be a county doing it themselves for the first time in 10 plus years and starting with a difficult sort of recruitment environment. These are just important things for this body to think about.
Okay, thank you.
Yeah.
Me? I just like to thank you, Mr. Kemper, for taking seriously the clients and the family members, and for bringing to the forefront, you know, the isolation and aloneness that we've all felt at one time or another, and I appreciate it greatly. And I gave him names from all around the county: Covelo, Gualala, Fort Bragg, Ukiah, Willits, and I thank you very much. Yeah. That's it.
That's it.
That's it. That's all I got.
Jan has
Okay. Thank you. Oh, wait, okay, Jan.
Yeah, I have two questions.
Sure?
So the first one was regarding the psychiatric health facility. And I was wondering if you had any thought of perhaps the benefits of a more regional facility. One of the examples that you gave was the Sutter Yuba facility. So would there be benefit like pairing up with Lake County or something like that for Mendocino County?
In those instances, what happened is that an individual county went forward to have a contract and then brought other counties on board sort of after the fact. And I think that that would be a reasonable model for Mendocino. Primarily because, let's just say for the sake of argument, that you're starting at 14 bed days per day. So of the 16 beds, you're going to need 14 of them. Okay. Well, then what you're doing is you're making that excess capacity available to other counties in the region. So you could have a regional model. But if your long-term goal, which we recommend, is to bring that number down, then it might be that you instead get down to 8 bed days per day, and now you have capacity for 8. The reason that we showed you that chart from the California Hospital Association about inpatient psychiatric capacity was to help you have an understanding of how little inpatient psychiatric capacity there is in this Northern California region, and what, comparatively then, what a robust market it would be to fill those additional beds. So I think our assessment is you start with what you need, but you create a strategy to try to reduce that need over time. And then as you free up that excess capacity, have contracts with counties in the regional area according to your terms and conditions that allows you to keep those beds full. There's you know, in running a facility, it's like running an airline. You want as many people sitting in the seats as possible before that plane takes off. Well, these facility operators want as many people in those beds as possible because each one of those is a revenue stream to support the facility. So the objective is to provide good care, but you still have to have a business strategy to keep it operating.
So my other question was regarding the supportive housing issue. And I was wondering if you had any examples of supported housing that's viable with the diminishing situation of licensed board-in cares in the state.
Well, I mean, I think supportive housing is a broad term by intention. It could be a small suite of apartments where people who have certain types of mental illness live and reside, and they have a staff person come over and meet with them weekly. That could be a type of supportive housing. Another type of supportive housing could be vouchers to get people into a short-term residential setting to help them stabilize on either a mental health condition or perhaps some type of drug condition, and get supportive services while they basically get stabilized in order to help them make decisions about the next sort of phase of their life. Another supportive housing concept could involve actual capital construction of units for people who meet certain types of mental health or SUDP criteria. There are lots of different ways to think about this, and we didn't presume that we knew the answer, other than to say we thought that more of these kinds of supports were necessary by virtue of what we learned, as well as some of the other work that's been done for your county around the homeless report that came out from Margaret and others, that said there's more that needs to be done here. Also, we know that there's a shortage of housing, generally speaking. So I think we basically called out that as a category, but then really deferred that for more deliberation and discussion about options.
Is there any kind of resource that would list the different types of support?
There may be, I think we'd have to do some research, it'll be fun.
Anything else? All right. Remember, I have a couple things, and I want to start with the same thing that many people said, is I've read this report several times myself, and what we were looking for is a snapshot of where Mendocino County is right now, and you've certainly provided us a good snapshot of numbers that are comparing us to other similar counties and the same situation we're in. And I certainly thank the voters for putting us in a situation where we can have a reality snapshot and we have hopefully the revenue to move forward. I have a couple questions. On page 45, you have the budget, the financing plan. Can I assume that the Regional Training Center for Mental Health was accidentally left out of that, of the income, so we can, because that's approximately 10% of the funds?
Right, and I apologize for that. What we should do is on that reserve set aside of 7.75, that roughly the $4 million, 3.75 should come out of that.
Okay.
And then I can redo the numbers and give you a new chart on that. But basically what it means is in years 6 through 10, there'll be proportionally a little bit less to distribute.
Right, got it, okay. As far as Mark's question regarding the cost of the mental health, and I appreciate the question because I have the same questions of, if you look at it like a business, money's going out and, you know, money's coming in, government is actually in the same sort of business because of the reimbursements. And one of the things that mental health has done, that I've learned since we went through the transition of going from government to private and nonprofit overseeing of the mental health care, is mental health has maintained the billing and the audit and review of what we're getting back from the state. And it's immensely helped. Is that fair to say? So I don't think anybody could give an absolute black and white number of what percentage is reimbursed by the state, because every year our questions are the same and every year the state reimburses differently. And so we're looking to hopefully build the mousetrap here that's going to get us as much revenue back as possible, knowing that we're still going to be in the red, but that's a cost of business, of government right here. Government's not made to be in the black, government's made to provide as much services as possible and you know, be in as least amount of red as possible. So, Mr. Kemper, approximately 30% of our citizens live on the coast. And in looking at table number 4 on page 17, 25.5% of all 5150s, the people who are going through the initial process of a mental breakdown, originate from the coast. And through your words earlier when we were talking about, you know, is Willits far from here or not? What's the definition of far? It's fair to say that Fort Bragg is far from here. You know, it's an hour and a half from Ukiah, an hour from Willits. In reading this, I haven't seen anything that talks about any type of services that would be new and improved on the coast. What's your thought on that?
Well, in a global sense, what we've pointed to is the importance of reaching out across the county. So that would include the coastal areas from Fort Bragg north and south. Have we called out specific services? No. But have we talked about wellness and related sort of expansion? The everything it takes strategy for severely mentally ill people, the substance use disorder services, and services regarding housing supports and what have you. All of those we see as being distributed in a way across the county so that more services reach people where they are. Now, if you want to ask specifically about a CSU, we didn't recommend a CSU get put in on the coast because it's expensive to run a CSU by itself. And we couldn't come up with a way to make the numbers work based upon the volume. If you wanted to dedicate money to that solely, you would be dedicating that to, you would be dedicating money there instead of doing something else. We think that there are better strategies to essentially make what is on the coast for assessment of 5150s and other conditions, make that complementary with the CSU that would be located in Ukiah. So did we talk specifically about the services? No. But do we say that they should be distributed across the county? Yes, we do.
So a crisis residential, I know we didn't talk about that on the coast, and,
Right.
you know, as a layperson in mental health, that I would look and say the Mendocino coast offers some of the most beautiful parts of our world right there, you know, hoping that it would help in somebody's recovery and after a traumatic emotional breakdown. Is it unreasonable and we're not asking you as you're the decision maker, we respect you as just an outsider from outside Mendocino coming in and give us the best advice possible. But would it be okay advice to think that we could go down the road of having crisis residential on the coast where it wouldn't be the emergency treatment, but it would be the recovery treatment?
Well, I guess what I would say is, where do you want to start? I would start with your shovel-ready project in Ukiah and incorporate the CSU, build a complementary structure on the CSU to the Mendocino Coast District Hospital and the crisis center there with our QMC. And then I would see how that experience goes with the current crisis residential in alleviating the need for inpatient psychiatric care. And then based upon the availability of revenues and the relative determination of need at that time, say, so does that make sense on the coast? Or does something else make sense on the coast instead? Now remember, concurrently, we're expecting that some of these other kinds of support services will be provided across the county, including in the coastal areas. But I'd start with what you have and grow into it.
When you opened today, you talked about the mobilization of services, you know, and credited the mobile services that are being offered as one of the more cost-effective ways of treatment that we're having throughout our county. Is it fair to say that if we increase the number of mobile services we'd have in our county, we could hopefully continue to see a decrease of the need of emergency services as well as crisis residential?
That, I don't know that I said it exactly the way you said it. What I said was that it was important and it was relatively small in comparison to everything else. But what I do want to say about what you said is the touching of people individually and the way that the mobile team, and it's not just mobile outreach, it's also mobile outreach and prevention services, that's an important ingredient, and that more of that, yes, I think could help remediate conditions for people who are suffering in their mental illness. Particularly if we can expand their ability to reach out to people and be heard at hours that aren't regular business hours. In the hours in the evening or in the morning, or at times when people find themselves most isolated. It's a structure that does that, and mobile outreach could be a component of that. You know, at one time in our recommendations, we had set aside a specific dollar amount for mobile outreach, and then we said, okay, we're getting too specific. We'll roll it into the wellness and expansion piece and call it out as something important. We think it's an important ingredient because of its ability to reach people one-on-one.
Thank you. On page 11, or I'm sorry, page 23, table 11, I think this was just basic knowledge that the Measure B Commission isn't going to have any input on, but I was amazed at the conservatorship cost to the taxpayer. That in Mendocino County, we have 61 from last year, 51 conserved people, and we're paying an average of $37,000 per citizen to have them housed outside of Mendocino County or inside Mendocino County, but just at $2 million. Is this a standard throughout the state? I mean, is that the normal cost of what it costs? And I don't know if you would know this, Is that the normal percentage of citizens that would be conserved in a county our size?
I'm not gonna go out online and say that I can tell you that this is the same as every other county or that the cost is the same. What I am gonna say is this is exactly the same kind of responsibility that every county has, and every county struggles with this responsibility for the same set of reasons that Mendocino County does. These are very difficult situations. Often the people need very high levels of placement. The number of locations in the state where that type of placement is provided are few. There is great competition for those placements, and counties, because they all have this obligation, and it's a court-ordered process, are under obligation to solve for that problem and pay for it.
No matter what the cost.
So it's a complicated problem. And the reason it's here, frankly, is when we met with Janine, one of the things we talked about were the conservatorships. And it occurred to both Jim and me that we thought it was important that your committee and that the Board of Supervisors be reminded about this important county responsibility, these individual people, and the amount of intervention and cost that's associated with it. That it wasn't some offshoot that was out here somewhere, but that in fact it was a part of the totality of the mental health delivery system for a specific segment of the treatment population.
No, I appreciate being included because it opened my eyes. I had no idea. You've answered my questions. Any other questions from the commission?
Just like
Mark?
comment, I'd like to say thank you. You did a very thorough job. It's brought a lot of insight and detail to a very complicated situation, so thank you very much.
All right, so we'll open up the public comment, and we'll go 3 minutes. Sorry, James. I'm sorry. You can state your name, and then while you don't have to do this, I'm going to ask everybody, if you could start by telling us if you did or if you didn't read the report.
James Morgan, MSW, former mental health specialist in 3 different counties, Sacramento, Placer, and Lake County. Those employees, I worked in 3 different capacities: a crisis worker, an outreach worker, and an LPS conservatorship case manager. One of the things I wanted to remind everyone is that there's a law that requires least restricted care. And as a conservatorship case manager, it was always my job to get these people out of these locked facilities, not necessarily keep them there. I was always looking for step-down facilities, and there's many levels, at least 5. But and those are the things we're missing in this county. As an outreach worker, I enjoyed that job. Getting out on the streets of Sacramento, where I knew mentally ill, were hanging out, homeless, mentally ill. Often businesses or law enforcement would tell us where these people were. I was able to get to them, get them into a lower level facility or whatever before they reached the point where they had to go into a psych unit. This is a very complex business, and we need to look at all those other levels of care and the components. We had a lot of them, and over the years we got rid of them, moving toward privatization. Daycare, very, very important. And you know, just the reaching out to these people. We in Lake County, we used to send a van out and pick everyone up. I had a doctor that told me bring the body and the mind would follow. And then, you know, and that's how it worked for us. We were able to keep an eye on people and see if they were de-escalating. And we just need to look at all of Mr. Kemper's report and consider all of them. You know, if we're just going to do crisis services or contract out to take care of other people's crisis people, you know, that's what we're going to do. But I don't think that's what Measure B was meant for. Thank you.
Thank you. Carol, better do that. Carol.
That's all right, go ahead. I can find it out another way.
Okay, doctor.
Oh, excuse me.
Hi, I'm Mills Matheson. I'm the medical director of the Better Creek Medical Clinic in Willits. and I've read the report several times. I agree with Kemper Consulting that a crisis residential treatment center and crisis stabilization in Ukiah would be the first priority for Measure B funding. And the other doctors at Bechtel Creek agreed with me this morning. However, we think that Fort Bragg would greatly benefit from a CSU, and this would significantly decrease the cost of the Mendocino Coast Hospital ER, which does need as much help as we can give it. I'm concerned, like many, about the financial viability of the PUF unit. Our last PUF unit was not viable. And the Kemper Associates do not propose any annual funding for the Measure B for the PUF. I think the PUF unit is going to need Measure B money to keep it alive. In June of this year, the Tri-County Healthcare District in San Diego closed down their 18-bed psych facility because they were having a $5 million annual deficit. We know about deficits here, the juvenile hall. There's tremendous financial risk with the PUF. I think we should partner with Lake County and share the financial risk. And finally, there's been a significant increase in 5150s. It's even worse. We had 107 in 2011, 417 in 2015, and now 645. There's been no careful analysis about why this is happening. Is it a failure of our psychiatric outpatient facilities, or are more mentally ill patients moving into Mendocino County being pushed out of the Bay Area? And finally, and I think the most likely thing, is that we are seeing the effects, the long-term effects of the mass use of speed in our community, which creates chronic and acute psychoses. Thank you very much.
Thank you, Doctor.
Thank you.
Mr. Cameron. Nolan, and you said you were, thank you.
Hi, I'm Mayor Kameroff from Willits. I did read the most of it, and mostly I'm here to ask a couple of quick questions, Mr. Kemper, who might have an answer, because first of all, there's a breakdown of the persons served by region, primarily for a PUF unit or for when they're brought in by law enforcement, and it breaks down 55% in Ukiah and 13% in Willits. And my question is, what percentage of these people are homeless? And so they may have been picked up in Ukiah, maybe they don't live there. Do you have a homeless percentage or approximation?
I do not, I'm sorry.
Because I was told that the PUF unit in Humboldt County, they say they have a 40% homeless of people who are brought in by law enforcement. Do you know that number? Any chance?
I don't have it off the top of my head.
Okay. And then my other question was, in light of the fact that 55% of the people are from Ukiah, and the two of the critical things Mr. Kemper mentioned about citing a PUF unit, one was access easily, meaning, partly meaning where the people are, the people who are being brought in, and the other thing he mentioned is keeping all the services in the community. Now, there are a tremendous number of services in Ukiah right now, and there are few, if any, in Willits. So in light of this, even if I wasn't living in Willits and concerned about it from a point of Willits, I would think that locating a PUF unit closer to all these services and to the ability for a community to respond in emergency situations. Willits has the volunteer fire department that's up to over 600 calls a year, and they are struggling to keep up with that, and a very small police department, and we all know Willits is in a struggling financially, where as opposed to, say, Ukiah with the new Costco or the coast that brings in tourist dollars that we don't bring in. And finally, keeping all the services in the community, that may be the consideration, is that Willits may not be the best choice to put one major PUF unit for the county. Anyway, thank you.
Thank you very much. Anybody else?
Yes. I'm John Fremont from Fort Bragg. Many, many years ago, some of you may not have even been born, I remember when Talmadge closed its doors to mental health. And the argument, and it seemed like a convincing one at the time, was that we need to bring people back into the community. We need to treat them in where they live rather than ship them someplace else. That's not true, but at the time I thought it was. The problem we have is, and it's not just in mental health or in behavioral science, it's all over the county. We don't have enough employees. There are bulletin boards filled with job openings, and we can't fill them. And one of the reasons why is because of the cost of housing. It's just too expensive. I had this idea about providing housing for a nurse or a mental health practitioner in a setting where other units for mentally ill or homeless was cited. That would be great for the nurse. They'd get close to free housing, and they'd also be able to keep an eye on the people who are clients or patients or whatever. I think we need to take a look at that because our costs for employment are staggering. Thank you.
Much. Anybody else? By all means.
Sherry Stambaugh, and that I did not read the entire report, but the comment about the stats on people that get picked up in Ukiah and this and that, I believe the Marbut report on the homeless says that all people who get picked up or whatever don't come, they do not come from here, they're from out of town. So even though those statistics are true, you have to look at what's kind of missing. You know, that's just my thought. Thank you.
Thank you very much. Anybody else? Any other closing remarks by the commission regarding?
I have a question.
Sure, Arnie.
I may need your help,
Okay.
Camille. I'm Arnie Mello, and I did read portions of the report, not the whole thing. And I struggle with acronyms too. A question that may have been answered, but if it was, I missed it, was in the report that we got from Helmer, there were actually 32 beds in that old hospital facility. 16 beds were for PUF. 16 beds were for
A mental health rehabilitation.
mental health rehabilitation.
Medical eligible.
So my question is mental health rehabilitation part of your recommended services for our county?
That's, I'm sorry, that specific proposal we didn't consider. However, it is one of the areas that's identified as a gap in service. So I think the point that you're making is that the cost estimate was for a combined facility. So what would be important is to differentiate between those two and segment out that that's related to the PUF from that that would be related to mental health rehab, so that an apples to apples comparison could be made. Contextually, in the financing scheme, we've identified the need for other kinds of wellness and supports, and we basically put rehab into that category of services. So we would defer back to the department on the relative need for that service. It's essentially another type of step-down service as an alternative to inpatient or crisis residential. Yeah. But I think if you could provide that to this committee and essentially delineate, here's what this would look like if it were done on its own, here's what this would look like if it were done on its own, this is the combined package, that would be a very informative thing.
Thank you.
Okay, we're going to be Dr. Berg.
So, received affirmation from Mr. Kemper about the crisis residential treatment project. And I get a sense of general agreement on that. I just wondered where we are as far as thoughts about moving forward on it.
Thank you very much. And so in September, I will be presenting to the board our Measure B monthly meeting results. And the Kemper report will be in the board agenda at that time, so they'll have had a chance to review it. I believe they're going to understand exactly what we've been talking about. The time is now to strike hard and move forward. So I don't know the answer to your question, but to the Board of Supervisors, we will certainly push them towards giving us an answer.
How about, can I make a motion then that we move forward on the shovel-ready project that Camille has prepared for crisis residential treatment, crisis access, and possible crisis stabilization unit?
They would be making a motion on an item that's not on the agenda.
Oh, okay.
So we could certainly put it on the agenda for next month to do it. And that way, the public notice and so forth. Anything else?
That's all.
Okay.
I'm wondering if you could clarify what you mean when you say move forward. What is moving forward?
Move forward is moving forward with the Board of Supervisors reviewing the Kemper report. And we have not asked the board, we've only asked the board actually two things, to reimburse the county elections people and to pay for the report that we have here. We're not asking the board to do anything at this point. I've been asking the board to review and comment on the Kemper report, and that's what I talk about moving forward. I don't think we're not, at this point, this commission hasn't asked the Board of Supervisors to make a hard decision on what's in here. I told the board most likely that's going to be in front of them in September.
So is moving forward accepting this report and
Accepting it.
providing it to the Board of Supervisors for their review and comment?
We certainly, that would be a fair motion for this board today to do.
Can you do it?
The corrected version that talks about the training facility though. Right?
Right.
Yes, sir, I'll.
Okay, all right, okay. All right, so is that a motion?
That can be a motion. I move that the Measure B Oversight Committee accept the amended Kemper report and forward to the Board of Supervisors for review and comment.
Okay.
Second.
Second, she had her hand up and you said it first. I'll go with Jan. So was that the second, Jan?
Yeah.
Okay. Any comment?
Yes.
Yeah.
It's a little unclear to me, what would happen then? You mentioned September, we'd be asking the board for what?
Hard decision. I mean, well, I don't know the answer. You know, at our September meeting, we're certainly going to, it'll be on the agenda. A review of the Kemp report is going to be on our agenda for September.
Okay.
And I would, at that point, would ask everybody to have read it as many times as Carmel. And,
at least.
And come with some recommendations, because the money's coming in, and the time is nigh, you know, it's to make a decision, so.
Shannon, what I meant by moving forward was making a recommendation to the board.
Yeah.
Yeah, and if I may, I'd like to clarify. I'm accepting this report saying we agree with its contents, but we are not necessarily, my motion does not include moving forward with any of the recommendations.
Understood, yes. It's just accept the report as presented by the consultant, sure.
Thank you.
And Jan, that's your second, right? Okay. Any more questions? Jan, or Carmel?
Yeah, I'm sorry, just one more clarification on your motion. Mainly because the board does have this report. They got it when we got it.
Okay.
So, but your recommendation is just that we as the Measure B committee accept this report in total. And then the report goes to the board for action, direction, whatever. But we're not making any recommendations out of the report right now.
Exactly. Thank you.
Dora?
Okay. To clarify for me, who has to put this stuff to the board. I've already submitted an agenda summary for our review to report to the Board of Supervisors at their September 11th meeting.
Right.
An update. So do I
Good enough.
edit that and include this report and attach the report.
I think, Tom, probably your update could include that the Measure B committee received the report, reviewed the report, accepted the report, and wanted the report to go to the board, and that's fine. And I don't know that you would need to do anything else.
Yeah, but I would appreciate if the conversation that was the extent of it, not that we are advocating for any more of these recommendations.
No, I agree with that. Yeah. Ross?
So accepting the report doesn't mean we take everything as fact. I have some serious concerns about, say, the $7.5 million budget for a building, for example, and I have some concerns about some of the assumptions made on what it's going to cost net to run say a PUF unit, as Mark was bringing up. So you're saying we're going to accept it, not necessarily believe it all. I don't know how else to put that. No offense, no offense, but I mean, you know, it's like I'm challenging those numbers, but I'm gonna. But that's not what you're not saying you accept those numbers.
Maybe I respond here.
Yeah.
I agree. No, I agree, and I think accepting this report in my mind is completely separate from the process that we would go through to do an RFP, as Mr. Kemper discussed. Those processes would hopefully flush out some of those questions that we have about the actual numbers and things like that. We're accepting the research that was done, the general principles outlined here, but each one of these recommendations, in my mind, is a separate and public and transparent action by this board.
Because it seems like the recommendation circles around some assumptions there that which are based on a kind of a verbal discussion, and I'm nothing I want to say. Oh yeah, I'm all for that.
Exactly.
All right, any more discussion about it? Okay, so we're voting to accept the report and submit it to the Board of Supervisors, which has already been. All in favor, say aye.
Aye.
Any opposed? Hearing none, so carried unanimously. Thank you very much. All right, we're going to go to monthly committee updates. We've already covered who will present and share the information. That was Measure C or 5C. I've covered that. Any questions about any public comment on Measure 5C, monthly committee update to the Board of Supervisors? Hearing none, we'll move to the last item, committee member reports. Each committee member will have the opportunity to report out of actions they have performed since the previous meeting. We'll start with Dr. Miller.
Sure. Just really getting through, reading the HIP report a couple of times and surviving 2 audits with the state.
Okay, you're surviving.
Surviving.
Jan?
Yeah, I just wanted to share that I went to the Oversight and Accountability Commission in Sacramento in July. That is the agency that oversees the MHSA funds. And it's always discouraging to see how those meetings are run compared to these other meetings. Also, for those of you on the commission or the board or whatever this is, who are lay people and don't have a lot of experience, unfortunately, up close and personal with mentally ill people, I want to introduce the NAMI Library. And we have some fantastic books to help you understand that whole world. So I have forms you can fill out so that you can borrow the books. They are available to anybody. All you do is fill out a card and return it to the NAMI Library. This one, The Body Keeps Its Score, is an excellent one. But this is our favorite. I'm not sick. I don't need help. If anybody's ever dealt with a family member who is sick and denial. So please, there's only 4 books, but you know.
So when you say they're in the NAMI Library, anybody can check them out and just bring them back. Got it. Okay.
That's right.
Carmel?
Nothing, thank you.
Doctor? Ross? Mark?
I don't have anything to report except I would like for us as a committee to read the document thoroughly and come back to this committee with an agenda. Basically, what you think we should do first, so we can move things forward, rather than look at one another and ask what we're gonna do. And I think it takes 3 or 4 times reading through this to get your mind around it, and we need to prioritize what we think needs to happen first, and when we do that in priority, we put money to that, and then we see what's left, and then we can prioritize from that. That's my personal opinion.
I agree wholeheartedly, and one of the things the board of supervisors heard from me for the last 2 months is get ready for September. You know, because we know that, you know, we need to move forward on this one. Thank you. Jed?
I agree with what everybody said about reading the report and having some focus for moving ahead. I continue to meet with people in my district where I've been appointed by. I was pleased to see Georgianne Krosky here for most of the meeting, who's the supervisor from their district. Lots of people from the district and Willits in particular. I've been meeting regularly with the Willits City Council. The next time they asked me to meet is on September 12th. So I will be meeting City Council and sharing and getting questions and feedback at that time, and continue to meet with whoever wants to talk to me anywhere about what we're doing, and hopefully together we'll come up with some good recommendations that will advance the cause of mental health in our community.
Good. Thank you.
Yeah.
Yeah, nothing really to report, except for I hope that, you know, this message about moving forward quickly and swiftly doesn't get confused with, we've already chosen a location and anything like, you know, this is, we still have a long ways to go, and so I want to make sure that the public and the community understands that these are not decisions about specific facilities or anything else. We're improving just the research.
True that.
Nothing, sir.
And I have nothing.
Wait, Donna. Yes, you do.
Oh, family to family? Family to family class will be starting September 18th. It's a NAMI class. There's flyers. Do you take to your, if you'd like to take some to Fort Bragg and Willits, that would be great, although it's hard for people to come over for an 11-week class. But it's for family members only. And it teaches pretty much everything you need to know for right now.
Is that available website anywhere?
It's on, it'll be on our website. I haven't done it yet.
The Ukiah, Mendocino County,
NAMI Mendocino County, yeah.
website. Facebook?
Facebook.
Well, website, okay.
Website.
All right. Thank you very much. We're 3:02 p.m.